Today's topic is nursing care at end of life. End of life is a phrase that refers to the final stage of life when death is imminent. No one can predict death, but there are physiological and often psychological manifestations that indicate death is approaching. The final phase of life may last hours, days, or even weeks. End-of-life care refers to the physical, psychosocial, and spiritual care that is provided to patients and their family members during the final stages of life. End-of-life care addresses issues related to death and dying and may include palliative care and/or hospice care. The goals of end-of-life care include ensuring comfort and preventing or relieving suffering by offering supportive care, improving the quality of the person's life, maintaining human dignity while respecting the patient's wishes and desires, and providing emotional support to the person and their family members, and in many cases their close friends, significant others, and caregivers. According to the World Health Organization, palliative care is any form of treatment that is given with the purpose of improving quality of life and preventing or relieving suffering. It often begins when someone receives a terminal diagnosis, but may be given concurrently with treatment that is intended to prolong life, such as chemotherapy or radiation therapy. Palliative care often includes hospice care, which is an approach to end-of-life care that focuses on reducing symptoms and providing compassionate support and care during the terminal phases of an illness. Palliative care and hospice are similar but differ in several key areas. Both palliative care and hospice seek to maximize comfort and decrease symptoms, especially related to pain and suffering. With hospice in particular, quality of life is emphasized over quantity of life. Palliative care is offered to anyone with a life-threatening diagnosis, including those concurrently seeking curative or life-prolonging treatment. Though included within palliative care, hospice only involves care at end of life. Palliative care is offered at any time without a time limit, whereas hospice care is limited to persons with a life-limiting illness and a prognosis of less than 6 months. Medicare and Medicaid do provide reimbursement for hospice care, but require an initial certification by 2 providers that the person's prognosis is less than 6 months. Patients may withdraw from or stop hospice care at any time, and if needed, they can continue to receive reimbursement past 6 months with recertification from only 1 provider. Palliative care services are offered in acute care settings, including the intensive care unit, in long-term care settings, and also in the home. Hospice services are also available in both inpatient and outpatient settings. Outpatient hospice services may be part-time, on-call, or continuous, and are usually available 24/7 for in-home support. Both palliative care and hospice offer bereavement support for family and friends following the death of their loved one. In addition, both palliative care and hospice care is administered with a highly collaborative interdisciplinary team approach. Teams include providers, nurses, social workers, pharmacists, and physical and occupational therapists. Spiritual advisors and counselors may also be involved. As a person enters the final stage of the dying process, the body begins to shut down. Metabolism slows and all body systems gradually cease to function. Respirations often shut down first, followed by cardiac function. The dying process ends when all physical systems cease to function. Dying is a natural process, and there are many normal physical manifestations that indicate the body is shutting down. There are both early and late manifestations, though the timing is unique for each individual. There is often a decrease in sensation and perception of both pain and of touch. Eyes may take on a glazing appearance, vision may become blurred, and the blink reflex may no longer function. The sense of hearing, however, is thought to remain intact and may be the last sense to leave. People often experience an initial increase in heart rate, followed by a gradual decrease in heart rate and blood pressure, and development of an irregular rhythm. Respiratory system changes include an initial increase in rate followed by a gradual decrease in both rate and depth. A Cheyne-Stokes breathing pattern characterized by alternating periods of apnea and deep, rapid breathing may develop. As time progresses, the person may experience a decreased ability to cough and to clear secretions, which may lead to noisy, wet-sounding respirations. As cardiac output falls and oral intake diminishes, oliguria develops and gradually progresses to anuria. Any urine that may be present is usually dark amber, brown, or reddish in color. Urinary incontinence is also common. Peristalsis in the GI tract slows and eventually ceases entirely, resulting in flatus, abdominal distension, nausea, and anorexia. Lack of appetite is common, as is loss of sphincter control and GI incontinence. Decreased muscle tone and function, including muscles of the jaw and throat, lead to difficulty with maintaining body posture and alignment, decreased ability to swallow and speak, and loss of the gag reflex. As death becomes imminent, integumentary manifestations include skin that is cold and clammy, mottling of the extremities, cyanosis of the nose, fingertips, nail beds, and toes, and an overall wax-like appearance. Physical signs and symptoms are a normal manifestation of the natural dying process, and the amount and degree of symptoms will vary widely among individuals. Care at the end of life begins with a thorough assessment. Both subjective and objective data should be collected. The focus of the subjective assessment will vary depending on presenting symptoms, the underlying illness, and proximity to death. Assessment data may need to be obtained from someone other than the patient. Begin with a thorough assessment of current symptoms and context, including recent medical diagnoses and treatments. When appropriate, ask about past medical and surgical history. It is also very important to review healthcare directives, including a living will, durable power of attorney, and physician orders for life-sustaining treatments, also called a POLST form. An example of a POLST form will be shown on the next slide. The social history should include a cultural assessment of preferences and norms surrounding death and dying, a spiritual needs assessment, and an inquiry into potential financial considerations or needs. It may be helpful to conduct a family history in order to learn more about the person's past experiences with death and dying. Throughout the entire process, attention should be directed to the personal desires, wishes, and choices of the person and their family regarding the death and dying process. This is an example of the POLST form that is used in the state of Washington. It includes orders for CPR, medical interventions, information disclosure, and non-emergency medical treatment preferences. It needs to be signed and dated by the person or their legally designated representative and by the healthcare provider. General objective assessment data includes overall appearance, affect, pain, and level of consciousness. Vital signs may or may not be assessed depending on the person's preference and provider orders. A functional assessment should be conducted to determine current ability and desire to carry out activities of daily living, the amount of food and fluid intake, and the amount and quality of sleep and rest. A psychosocial assessment should include the person and their family or significant others' current coping ability and strategies, and the presence or absence of family and social support. A spiritual assessment should be conducted, noting any signs of distress or despair. Others may have a strong spiritual and faith support and may not show any spiritual distress. Death and dying, however, often stimulates deep-seated spiritual questions or convictions, and a thorough spiritual assessment is very important. The physical assessment is often abbreviated and should be focused on symptoms and physiological concerns or distress. Nursing management at end of life should be prioritized in order of physiologic need. Gradual decline in body systems is expected, and care should be focused on preventing or relieving pain and optimizing comfort. Ineffective airway clearance and impaired gas exchange are related to decreased function of the respiratory muscles. Decreased cardiac output is related to decreased metabolism and decreased function of the cardiac musculature. Bowel and bladder incontinence result from decreased smooth muscle function, and pain and impaired comfort may be related to any number of factors, including underlying disease processes, decreased mobility, or skin breakdown. Psychological concerns may be highly significant for the person and their family, friends, or caregivers. Common psychological concerns may include fear, anxiety, or anger, social isolation, grieving and sorrow, spiritual distress, and interrupted or dysfunctional family processes. Nursing interventions should be prioritized according to physiologic and psychologic need. Comfort, pain, and psychosocial needs should be closely monitored. Certain medications may be administered in order to alleviate symptoms. Commonly administered medications at end of life include analgesics, anxiolytics and sedatives, ocular lubricant, and anticholinergics. Anticholinergics are administered in order to decrease both the amount and viscosity of GI and respiratory secretions. Additional comfort measures may include positioning, providing comfortable clothing and bedding, applying lip balm, using gentle touch, and arranging a soothing and relaxing environment. Additional nursing interventions include supporting and educating the patient and their family or caregivers. Important topics to address include provision and allowance for adequate sleep and rest, amount of food and fluid intake. Family members are often very concerned by their loved ones' lack of appetite and decreasing intake. It's not uncommon also for the dying person to attempt eating and drinking despite their lack of interest, simply in order to please their loved one. Education should be provided that normalizes decreased appetite and thirst as part of the dying process. Alternatives might include using mouth swabs or ice chips to prevent drying of mucous membranes and to ensure comfort. The physical environment should be arranged in order to maximize comfort in whichever way is most desirable to the person and their loved ones. Simple things such as lighting and noise levels should be arranged to best support the person and their unique preferences and desires. Family and friends should be encouraged to be as involved as possible. Most people desire to be surrounded by people they know and trust during the dying process. Cultural considerations should be a priority. Cultural beliefs and values regarding death and dying are highly varied and may be very, very important. Every effort should be made to adhere to the wishes and preferences of the dying person. Education may also need to be provided regarding post-mortem care and funeral arrangements. All of these interventions should be implemented with patience, empathy, and compassion. Following the death of their loved one, nurses are in a unique position to provide bereavement support to the person's family and friends. Both palliative care and hospice provide bereavement to help people begin the process of saying goodbye to their loved one. Grief support services are incredibly important and are often included in nursing care at end of life. The overall goals of care at end of life are to maintain comfort and ensure effective pain control. Additional outcomes may include the use of appropriate coping strategies and maintenance of dignity and respect. This concludes the presentation on nursing management at end of life.